Thank you very much indeed. And it's quite dangerous, at least for oncologists, to ask a surgeon what he's thinking about his own heart. Is one of the reasons because I put in my conflict of interest that I'm a surgeon, and on the other hand, I will try to give you in my talk, rather than personal experiences by referral center, just an overview on what we did as a surgeon in the last years. Just a little of history. Since we have to look at the changes, we have also to look on where we are coming from. And the milestone for a pancreatic surgeon is a Whipple procedure, and the Whipple procedure was performed in 1935 by a great surgeon who is Professor Whipple, and he did a second and 2 stages operation, and the patient died 25 months after the operation for liver metastasis. But what is much important in my opinion, is that at the end of his career, Professor Whipple performed just 37 operations. So at that time, a pancreatic surgeon was really a pioneer. But looking at where we are, I refer to this beautiful article published in Annals of Surgery almost 70 years later on Whipple procedure performed by himself. And this is referral to 1,000 pancreatic duodenectomy performed by a single surgeon who increased his own experience over the time. The median operative time was at the beginning 8.8 hours, and at the end of his experience was 5.5 hours. And on the other hand, the postoperative state started from 17 days to 9 days, and thereafter postoperative mortality was reduced to 1%, as well as the overall 5 survival was 18%. This professor was Professor Cameron, who is still working, I suppose, in Johns Hopkins, and in March 2012, he was celebrated by his pupil because he performed by himself 2,000 pancreatic duodenectomies. So far, looking at the history, we may say that nowadays, pancreatic surgeon looks like, rather than a pioneer, more pilots of Formula One. And the reason is that there is not only limited experience by Professor Cameron, but on the other hand, we can recognize worldwide at least 30 centers where this experience has achieved these good results. And you may say, whoa. However, if you look at the data of these are reported by, I like this, fact sheet. And you may see that the percent of surviving patients after 5 years did not change over the years, as well as the forceps in between new cases and that remain very tiny. So where is the truth? We have to consider many aspects depending on technology, biology, and organizational matter. Moving quite quickly around the technique and technology, what we did as a surgeon with good results, I would say. We standardized our techniques. We adopted new devices which became available, IDAST, harmonic scalpel, stapler. We perform a randomized clinical trial on technical aspect without saying what is better or not, just according to a gut feeling. And we introduce these new approaches, such as laparoscopy and robotic. Just for you, I would like to remind that is the mini-invasive surgery in pancreatic surgery is still demanding the approach to the head of the pancreas, is easier for body tail, not worldwide accepted and available, less blast load, and shorter postoperative stay, as safe as the open approach. But the still matter of research. What we did also is to recognize in referral center the value of less invasive technique for palliative purposes, and it means that we have definitely reduced the number of unuseful or not resectable operations, and we introduce also a standardized perioperative protocol for patient management, such as what we call enhanced recovery after surgery. So what do we mean as a good results? In terms of perioperative outcomes, looking at the literature, we have a morbidity rate which is around 40 to 60%, a mortality rate in referral center which is less than 3%, and the median length of hospital stay which is around 10 days. But in terms of oncological outcomes, the lung lymph nodes that you can find in the specimen or has been retrieved by surgeon is around 22. The R1 on classical margin, you have just heard a discussion about this, is around 20%. And we are able to send to you, as oncologists, 60 to 70% of our patients for adjuvant purposes. The median survival in referral center was around 27 months, and once again, 5-year survival after resection is around 20 to 30% of cases. But when we look at the biology, probably biology and surgeon are two words who are not get on well together, because we try to overcome many barriers. Arterial involvement, venous involvement, minimal metastatic disease, as well invasion of adjacent organ. Just to keeping in mind the list, looking at arterial involvement, there are many studies published in the literature, but as you know, we have the help of this systematic review, and you may say that all these studies reported retrospective series with a high risk of bias. However, perioperative mortality was definitely higher when we perform an arterial resection, as well as the oncological, I would say, less onco and less logical are quite worse, since we have a risk to lose our patient within 1 year in 50% of cases. And I would say that arterial resection for surgical standpoint should be a tombstone. However, there are a long discussion among surgeons as regards the venous involvement. You have just heard about the definition of borderline resectable and so far. Once again, a very recent meta-analysis published in British Journal of Surgery. They started with 1,000 articles. They look at 27 for these purposes. And once again, the purpose is to achieve a better rate of R1, R2 resection. It is not true anymore, since the meta-analysis showed quite well that the percentage of R1, R2 resection is much higher in comparison to R0 resection without venous resection. And once again, the risk of losing the patient within 1 year after the so-called radical surgery, once again favors standard procedure. And we do not have the percentage of patients still alive after 1 year, but we may recognize very poor results as regard median survival of 14 months when a venous resection is performed. Minimal metastatic disease, a very hot topic in this setting. The story starts from Heidelberg Experience, who published this article in Annals of Surgery in 2011. And you may recognize that the 10% of patients with minimal metastatic disease into the liver have a very poor median survival of 12 months. And this is even worse when outside of a referral center where the median survival was 6 months, and once again, paying a very high risk of postoperative mortality of around 20%. What about minimal invasion of adjacent organs? One again, not negligible damages. I have just showed this to Thomas because he's still online on Annals of Surgery. Is Germany from 2009 to 2013. And you may see that pancreatic resection is associated in general with a 10% mortality, but when we resect along with the pancreas, the stomach, these mortality increase up to 90%, even higher when we resect either the small bowel or the large bowel, visceral arteries, and as you know very well, visceral vein with very poor results. This is the series published by another German school, and you may see that we are losing within 1 year at least 55% of the patient. So there is another thing that we help you to recognize that the surgeon and biologist does not get really well together, because you may see this article and the percentage lost after a surgery for radical intent after 3 months is 7%. After 6 months, is already 16%, not because of complication, but because of recurrence of the disease. And within 1 year, we have already lost at least 37% of cases. So enough for saying that the pilot is with his button on the ground. However, depends, because sometimes biology allows the surgeon to do something else. And looking at the list, I would like just to show you these retrospective studies that whenever a venous resection is performed in upfront surgery, definitely the overall survival is definitely worse rather than standard resection. But this is not any more true whenever the same resection of the vein is performed after neoadjuvant therapy. And what about minimal metastatic disease is a very hot topic in the literature. It is the only reference to our own experience. We have taken from 3 main Italian centers 127 consecutive patients with the liver metastases. And you may see that in a small proportion of that, we were able to resect both the tumor and the metastases with a very good median survival in those patients who were resected. However, surgical resection was carried out in a few proportion of patients. The preoperative workup was very careful, and all these patients were operated upon after a median of 12 months from initial diagnosis and multi-regimen chemotherapies. So in other words, more than careful morphological and biological selection. So keeping in mind that in oncological setting, the king remained the biology. However, the surgical eagle might fly sometime only when biology allows it. There is a very sad story which belongs to the organizational matter. We know that pancreatic surgery is very demanding, and this is less demanding when the pancreatic surgery is performed in high-volume center. And this is once again demonstrated in this cartoon, and you may see that the results are not better just in terms of post-operative outcome, but also as long-term outcome. And the Dutch, I don't know whether or not Dutch oncologists are here, were very virtuous because they apply a specific program in this setting, and they were able to reduce the number of patients operated upon in small volume hospital, decreasing the mortality over the years. However, I have also to remind the United States, not because I hate the United States, but just because they started with the registry many years ago, so many data are available. This is just for patients, 10,000 patients with stage 1 disease. According to the stage, only 1/3 of the patients were operated upon. And on the other hand, 2/3 were not. And in the majority of cases, was not just because of any reasonable reason, but without any reason. And we will be back in this. And unfortunately, this is the last update of this experience in 2016. Nothing has been changed yet. So the cruel reality is that our patients sometimes has refused from surgery because of age, because of race, because of ethnicity, marital status, as well as their economical status, whether or not they have an insurance. And in Italy, it is not different. These are data from my own country, and you may see that pancreatic surgery is performed in 89% 99% of the hospital with less than 5 resections a year. And despite the overall mortality is better rather than reported by Germans, same 0.7%, this is definitely related according to the volume of the hospital, with the risk of death which is at least 3 times more for a patient operated upon in a low volume hospital. So in the shoulder of a patient who has got already the complaint of the disease, we had the luxury of care since this patient has to take some cars according to the volume of the hospital where he is operated upon. In my opinion, despite surgery, I would like to ask you whether or not is this acceptable anymore. So looking at whether we have improved over the year, looking at technology and techniques, probably I would say yes, we have improved as a surgeon. And on the other hand, looking at the biology, there is still conflicting results, and I will be just in one slide on this point. And looking at the organization, probably they are still a red light. Most of the results are still depending on how the pancreatic surgeon is. And optimal results might be achieved when the pancreatic surgeon is biological oriented and on the other hand, technically skilled. They are uncertain to what worse, I would say, when the surgeon is technically skilled but biologically disoriented, and they are definitely disastrous when the surgeon is technically unskilled and biologically disoriented. Despite the progresses, there are still a long way to go together, and I would like to thank you for your patience.